talking about one of my clients. Her name is Mrs. Beverly Webb. She's a 40-year-old female who has been diagnosed with primary diabetes mellitus in type 2. She's currently obese with significant intra-abdominal adiposity. She walks her dog once a week, so she's for about 30 minutes, so she's pretty inactive at the moment. She's a housewife who lives with her husband and 5 sons. There's no relevant family history, nothing to do with type 2 diabetes that she has let us know about. She's not pregnant, she's never smoked, and does not drink alcohol. She has been prescribed metformin. Okay, so insulin release for the normal person happens when the blood glucose levels are high, such as from eating a cheeseburger and you've got tons of glucose all in your bloodstream. Okay, so the pancreas will then go, oh, wow, we have so much glucose in us, we need to fix this. What's going to fix this? Insulin. And so it makes insulin and it releases it in a biphasic manner. So the first phase is the rapid, quick, acute sort of mechanism where it gets all the stored up insulin that it already has and just sends it off out there to try and reduce the blood glucose levels. The second phase is where it actually has to create it and make fresh insulin to be released, which takes a bit longer. Okay, so in essence, you've got the bloodstream with glucose in it, and then the pancreas goes, oh look, we have glucose in our blood, and so then it will produce insulin, which will help fix it and counteract it. Okay, so that's in a normal person, but in Beverly, what's happening is two things. So she's either having defective insulin secretion, which means that her body is actually struggling to release the insulin, which can happen because of islet cell function or beta cell mass. It's a very contentious issue. Or it also can result from a reduction on the first phase insulin secretion and irregular auscultations of plasma insulin. But the second thing is insulin resistance. So binding to target tissues in a normal person, what actually happens is that the insulin is already in there, the pancreas has already worked it out, put it all in the bloodstream as well, and it's actually a really large peptide molecule, and it will bind to its particular receptors on its particular target tissues. So that means fat, liver, or muscle cells. So what actually happens is the receptor-bound insulin is what triggers certain GLUTs, which will pick up the glucose and take it from the blood, and therefore it will reduce the blood glucose levels. So basically, in essence, you've got the bloodstream, and then there's a little glucose, which is all in the blood, and the insulin has already been put in there, and so the insulin will bind to its particular insulin receptor on the cell, so say that's a fat cell or something, and which the receptor, binding to the receptor means that the GLUT is triggered to then go and pick up the glucose and take it out of the blood and keep on picking up and dropping off. So it's dealing with the glucose and getting it out and overall reducing the blood glucose levels, which is what you want. Okay, so in diabetes mellitus, so say for our lovely Beverly, most likely she will have fewer receptors, and when the binding actually happens, for some reason nothing's happening, there's something missing, there's some decreased ability of the tissue to respond to insulin as it's not recognizing it. And so initially this is hyperinsulinemia, and the pancreas will freak out and make heaps and heaps of insulin, which stresses out the beta cells and means they don't work properly. So they're just trying to fix it, why isn't a regular long-term hypoglycemia can have severe consequences. It can lead to retinopathy and renal disease, and these are both really serious and caused by osmotic cell injury. This is basically where any cell that isn't a muscle, liver, or fat cell, basically the GLUTs don't need insulin to be able to take glucose out of the blood. So the GLUTs are just going to go, oh, there's insulin, they're just going to take it all out and put it into the cell, but eventually this can cause the cell to burst. So for in the retinal cells, like the eyes, that cause like blindness, aneurysms, bleeding, blurred vision, it's really serious. And in terms of renal disease, it affects the glomerulus, and it doesn't function as it should anymore. That means albumin is found in urine, protein, there's whole problems with edema, because there's no osmotic force to pull the fluids back in again. It's inflamed, it's damaged, it's really serious. I believe that Beverly's low level of physical activity was definitely a major risk factor for her getting type 2 diabetes. The fact that studies show that those who are physically active have a 30 to 50% lower chance of getting type 2 diabetes than those who are sedentary, like fixed volumes. And the fact that risk reductions are said to be with as little as 30 minutes of moderate to intense activity per day. So just doing exercise once a week isn't enough. You've got to do more than that, and it can have favourable effects on body weight, insulin sensitivity, glycemic control, blood pressure, endothelial function, and inflammatory defense systems. All these will help to reduce type 2 diabetes. Discussing with Beverly before the significant role that obesity can play contributing to type 2 diabetes, and we both were discussing that the more fatty tissue you have, the more resistant your body can actually become to the insulin, as the high levels of free fatty acids, which is what happens when you're obese, is what can inhibit the target cells from responding to the insulin. And so it's important to realize that obesity is a major factor and something that must be considered and prevented and controlled. Beverly's currently on metformin, which is really ideal and really great for people who are obese or overweight, as it won't cause them weight loss, or generally it's less likely. Okay, so what it does in terms of pharmacological effects is that it increases the glucose uptake and utilization by muscle cells, decreases hepatic glucose production, decreases LDLs, improves insulin sensitivity by increasing the number of insulin receptors, and also increasing the affinity between the receptors and the insulin itself. Pharmacodynamics, it alters the energy metabolism of the cell, especially liver cells. It inhibits the hepatic glucogenesis, which is making new glucose from non-glucose sources, and it processes glucagon action, which is really good, and it's a great drug, and that's why she's on it.